Welcome to the Dr. Geo Prostate Podcast. Today's guest is Dr. Jeffrey Tosoian, a leading urologist and researcher at Vanderbilt University Medical Center. Trained at the University of Michigan, Dr. Tosoian now works across Vanderbilt's main hospital and its Bellmead Oncology Clinic. He's nationally recognized for advancing prostate cancer screening, most recently with MyProstateScore 2.0, a non-invasive urine test helping men avoid unnecessary biopsies. Now, let's join Dr. Geo and Dr. Jeffrey Tosoian.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, where it is my intention and my goal to help you understand prostate issues, empower you to take action, ask better questions with your physicians, and everything to do with prostate cancer specifically, which is going to be our conversation today with Dr. Jeff Tosoian. Jeff, such a pleasure to have you on.
Pleasure to be here. Thanks so much for having me.
Man, this is my first faculty member from Vanderbilt that I ever have on the podcast. Yay. I mean, I'm such a fan. I'm such a fan of the group there. I'm such a fan. Well, my son loves baseball, so he's always talking about the Vandy boys. Yes. You know, I'm surprised he doesn't have posters up of the Vandy boys right now. He's 12 years old. My daughter just came to me the other day, and I knew this. And she said, "Dad, I think I love country music." I was like, "Can we ever go to Nashville?" Because I heard, yeah, you heard right. There's a good country music there as well. So there's been a lot of Nashville, Tennessee in my house in the past couple of years. So I'm glad to have you on.
I'm very grateful. Thanks so much. And I agree with you. We have a really great group here and a pretty darn good baseball team too.
That's right. Jeff, so my audience, the patients I see, everybody I see, they want less is more, right? They're saying, I don't want to get biopsied. And I mean, I don't know any urologist who wants to get biopsied, right? Even though that's what right? No one wants to get biopsied. So,
of course,
the old line that I have, I think members of this audience have heard several times, is no one wakes up in the morning and say, "Man, I can't wait to get a biopsy today." Ever. I never heard that. So, in the past with overuse of PSA or misuse of PSA, that was the case. And then overtreatment. Things have gotten better in that result. Thank God. I always say, if you have to have prostate, no one wants prostate cancer. If you have to have it, this is the best time to have it. A lot of tools to use and so forth, including to prevent or at least temporarily unnecessary biopsy, that is.
Yes.
What is your approach? And I know now is MPS2 and what MyProstateScore 2 right now. What has been your approach? Because we're going to dig into MPS2 in a second, in terms of trying to figure out who absolutely needs a biopsy and how do you think about it?
Yeah, absolutely. So, as you know, right, PSA is of course our first line blood test. And for the listeners, I'll mention a PSA greater than 3 is considered elevated. So back in the 90s, right, when a PSA greater than 3 meant you got a biopsy, we learned that upwards of 80% of those biopsies turned out to be negative. And so, that's what started a lot of the controversy surrounding PSA and questioning whether it should be used at all. Mm-hmm. And what the solution was, which is the path we've gone, is saying, okay, PSA will be elevated in the majority of men that have prostate cancer. Mm-hmm. It's a relatively sensitive test for prostate cancer, and particularly for prostate cancers that will prove to be lethal, as we've learned from the Swedish data. And so it's a good starting point. The problem is that, again, as you're familiar, among men with an elevated PSA, there are many other things that can be causing that elevated PSA other than prostate cancer. And so we needed better tools to take that population of men with an elevated PSA and say, okay, we can rule out the need to perform a biopsy, right? Rule out the presence of a clinically significant prostate cancer, which is the term we use to describe cancers that need to be treated. And so MRI and biomarkers have come along to that end, and both represent good options for identifying who will benefit most from a biopsy and identifying those who do not need to undergo a biopsy. And so, with those being the two main tools in our toolbox, I do think both are reasonable options. There are some factors that in certain cases would make me lean toward one over the other. That would be particularly, right, if we're coming at this with, okay, patient comes in, has an elevated PSA. As you said, our goal is to not have to perform a biopsy unless we can be pretty darn sure that there's a cancer there that we need to detect.
And just to interrupt you for a second for our listener, you heard that. Their goal, and I know this Vanderbilt and certain institutions, is not to do it. Many of you think, well, they all want to do a biopsy. They must have kids in college because all they want to do is biopsy. This may be true, by the way, in some places, some clinics, they'll biopsy anything, by the way. So, there is some cynicism that's probably well-deserved. But most people, certainly most physicians I know, urologists, are very responsible and actually don't want a biopsy if they don't have to. So I want to emphasize that, because I think a lot of people in our audience, reasonably so sometimes, particularly if they've had one or two bad experiences with urologists, they just think, oh my God, it's all business, and they're just trying to make money off of us. And that's not always the case. I thought this would be the right time to stand up for urologists. So
it's a great point. It's a great point you make, and like you said, being fair to both sides, there probably are some folks that, I would hope it's not a conscious decision, but subconsciously that's at play. But I think the vast majority of urologists, most physicians in general, right? You want what's best for the person across from you. Yeah. And you're thinking of that patient as you would yourself and your closest family members.
That's right. Family members you actually love.
That's right. That's right.
So you were saying, so we have these biomarkers, we have MRI. What do you do? And we won't get into the biomarkers because, is this 4K, select MDX, ExoDx is a urine, Phi. We've spoken about it with others in the past. So there's several episodes where we talk about ExoDx and 4K score. And I want to hone in into MPS. But what do you do when there's a discordance between MRI and any biomarker, let's say? So the PIRAD is 4 in an MRI, but on the biomarker shows low risk. What wins?
Yes. So that's a great question. And I'd love to even go back a step from there.
Sure.
When we talk about, which to use out of those. It's very possible that we do someday, potentially someday soon, get to the point where it is, feasible to get both an MRI and a biomarker test in all patients. For now, I tend to think I like to approach with one over the other, and I'll tell you my thought process there.
Please, yeah.
And the thought is just, right, I want a reliable rule out test if we're going to not be performing a biopsy in a patient with an elevated PSA, which, again, that should be the goal, and that's the reality. Most men with a moderately elevated PSA, we now know from years of data that they won't need a biopsy, but we don't know exactly which ones do and which ones don't yet. And that's where these tests come in. When we talk about ruling out, so, a high negative predictive value, meaning that when the test is negative, how sure can we be that if we performed a biopsy, that would also be negative? And biomarkers, that is one area where biomarkers have generally, and we'll talk about some exceptions and specific settings, but generally biomarkers have demonstrated negative predictive values in the mid 90%.
Define NPV for our audience real quick.
Absolutely. So if a test has a 96% negative predictive value, let's say, that means that if you have the test done and the result comes back as negative, the likelihood that one would have a clinically significant prostate cancer despite a negative test is 100% minus that negative predictive value. So with a negative predictive value of 96%, that would tell us a 4% chance that a biopsy would detect a significant cancer, or 1 in 25.
Right, so, meaning that the test didn't give you the result, the accurate result, and only 4% of the times in that scenario. And to put things in context, as people say, "Well, why not 100%?" Well, nothing is 100% in medicine, and 96% negative predictive value. Anytime you see those numbers, that's really good. That's really good.
Yes, and that was part of so when I went back to the University of Michigan as a fellow in 2018, the first iteration of the MyProstateScore test, the MPS test, was available clinically, and Dr. Chinayan, who was my mentor there and whose lab developed that test and who I worked with in our development of the second version, said to me, "Is this a test that we should be getting out there clinically?" It really hadn't been commercialized. It was available through the University of Michigan, but not many folks knew about it. And we had all the data from large trials. And I said, let's let the data answer that for us. And one thing that, with a lot of input from others, a lot of teamwork, one thing though that I had always felt very strong about was having that very high negative predictive value. At the time, there were some other tests available that had negative predictive values in the high 80s. So let's say 88%, which means that if you have that test run and the test is negative, there's still a 12% chance that there's a significant cancer there that we would be missing by not performing a biopsy. And so that was when we went to do the clinical validation of that test. I said, we need to have a negative predictive value that's 95% or higher. I want to be able to sleep soundly at night after deciding not to do a biopsy in the patients that have a negative test. And so that is, in my opinion, the most important thing when we talk about a rule out test. And that is why when we talk about the population on the whole, I tend to favor biomarkers as that first line rule out test. And that's because, as you may know, at our large academic institutions, at centers of excellence, there are pretty good data that show MRI has a decent negative predictive value of about 91% across many centers. Mm-hmm. When we look at other sites, not at these large academic research institutions, that negative predictive value of MRI is more on the range of 75%. And so, as you intuit, that means that a negative MRI, there's still a 25% chance of clinically significant prostate cancer, a prostate cancer that could cause harm. And so that's why I tend to favor first line use of biomarkers. And then in patients that can't be ruled out, so in patients that have a positive biomarker test, that's where I would recommend proceeding with an MRI. Because
you would not order both at once. You would see what the biomarker tells you, and only if it indicates, yep, we need to look further, then you'll order an MRI.
That's generally my approach. There's nothing wrong with ordering both. Like I said, the only potential downside is cost. And getting to your original question, how do you decide when the findings are discordant? We don't have great data right now to answer that question. And so it is a scenario where I see biomarkers with at least 92%, upwards 92, 95% negative predictive value. And if I want to rule out the need for biopsy, I see limited impetus to order both tests at one time when we know that that in that ruling out role, that biomarkers really are highly, highly accurate for us.
Well, that biomarker that's really accurate, it sounds like right now is only one of them, I think. And so so for the audience, Jeff has written, he's a primary author of numerous papers and major journals around MyProstateScore 2.0. And he's, as he said, he's looked at it since, I didn't realize that, since 2018. So this test better than most, I think, at this point.
Yeah, I think that's fair to say.
Wow, I really do. So when our colleague Ash from Northwestern said, look, I'll gladly be on, but this is the guy you're going to talk to. He's right. He's right. I had no idea that not only were you the primary author, but that you've been involved with this test for so long. All right, so let's get right to it. MyProstateScore 2. So this is a biomarker that I have never used yet. I think I'll be using it soon to help you determine whether or not we need to move on, whether that moving on is an MRI likely. And I want to be sensitive also because we're in a bubble. MRI, sure, 3T Tesla, right there, right here. Just go around the corner.
Yes.
This is not available to most people around the world, and certainly even in the United States is not widely available. So while that is the best technology and the best of the best are there, sometimes radiologists reading the slides are great. Most people don't have that. So right. I want to be sensitive to that. So if you have a urine test that you could literally order, by the way, I know you're not going to say that, but you probably will imply like MPS 2.0, and based on the research seems to be more clinically relevant and important compared to the others because that's been looked at. But whatever you have is better than just PSA, right? If you have a 4K, if all you can do is a 4K Exo. So we want to make clear that all these things, all these biomarkers are better than just PSA alone for the most part. And in some places, there's no MRIs or things. So these tests become really important.
Yes. No, it's a great point. And, when I talk about this with colleagues or at conferences and whatnot, I always say, listen, if you're at Vanderbilt, Michigan, Hopkins, NYU, one of these centers where we know MRI is in that 90% range for negative predictive value that's been shown and published, by all means, it's very reasonable to go right to an MRI.
Yeah.
The problem is that the vast majority of patients are not seen at those centers, and we similarly have excellent data that show that the negative predictive value of MRI is completely dependent on where it's performed and who is interpreting that, the radiologist that interprets that. And so
I've seen some big difference. I mean, I'm talking about PIRAT 4 brought down to a PIRAT 2. That changes everything in terms of how you approach 100%. This patient. 100%. Let me ask you this. Welcome to the Dr. Gio Prostate Podcast, where I bounce around a little bit, but eventually we bring it all together. We eventually bring it all together. We tie it all in.
Of course.
PIRAT 4, right? So here we have, this is just a case, 62-year-old man, a high PSA, PIRAT 4 in some remote place. I'm like, look, I don't know that I trust this. We do an MPS2, and that looks favorable. Should I trust the MPS? I mean, based on the research, you have to say yes. Should I trust the MPS2 and just say, look, based on this test, it seems like you may not need a biopsy. Obviously, we'll follow up and do all the right things to make sure we're not dropping the ball. How does that sound to you?
Yeah, it's a great question. And I have a couple of thoughts there. One is that, again, unfortunately, we don't, or at least those data have not yet been published.
We're in the trenches here. The
I know.
data is not going to show us, as good as it is. We're in the trenches. We have to make a decision here still. I wonder, what would I say? I probably would say, well, I'm at NYU, right? So he's like, okay, let's bring those slides here, or maybe do it here, right? But sometimes that's just not an option for people. So I'm wondering, MPS2 favorable. You know what? We can hold off. And will that trump, no pun intended, the MRI? Hello, friends. I just want to give a warm welcome to our next sponsor, LinkedIx. As you know, 1 in 8 men will develop prostate cancer during their lifetime, and screening does matter. But common approaches like PSA testing alone can be misleading and oftentimes is elevated for reasons that are unrelated to cancer. That's why LinkedIx developed MyProstateScore 2.0, which is a simple, non-invasive urine test that helps you understand your true risk of having clinically significant prostate cancer. We're talking about Gleason 7s or higher. MPS2 uses 18 unique biomarkers to give you a personalized prostate cancer risk score. The test is accurate, whether your urine is collected in the doctor's office or at home, and is designed to help you and your doctor understand what is the next step, whether there is more testing involved, imaging, or a biopsy. Talk to your doctor today to see if MPS2 is right for you. Visit lynxdx.com, that's LYNXDX.com, or look below in the show notes for the LinxDx link.
Yeah, at risk of showing my, familiarity with the MPS2 test and the data, I do feel comfortable that a negative MPS2 is negative, right? We've shown in the data that depending on exactly which patient group we're looking at negative predictive values, again, in the mid to high 90s. And actually, in patients with a history of a negative biopsy, the NPV has been 100%. And personally, having seen those data, and it is not a small number of patients, I do feel comfortable enough holding off on a biopsy, right? These are patients that we tend to continue to monitor.
Sure.
There are some practical considerations there that if it's a patient who there's some concern that maybe they could be lost to follow-up, that's obviously changes the equation.
Would you do another MPS2 in a year and it may actually change, either favorable or worsen?
Yeah, we don't know the answer to that just yet. But again, I believe that it does as good a job of any test as representing what is in that prostate, what's harbored in that prostate. And so if potentially there was no significant cancer present, though one develops over the course of a few years, my presumption, my belief would be that would be reflected in the test. Though, as I'm always maybe too quick to say, if we don't have data to tell us that definitively, have to be transparent about that. But these are the next steps in the studies we're working on now.
Good. And look, I love the adherence to the science, what the science, going by what the science tells you, right? I love it. I've been in an academic institution as a naturopathic doctor since day one, and I wouldn't have it any other way. I love grand rounds. I love all these things. And sticking to the science, again, at the end, sometimes it's like, man, you never see textbook patients come in. You always see things like, okay, what do we do now? And you have to do the best thing that you can for them with what you have.
100%.
All right, so we've gone a little bit further. Now let's come back a little bit. All right, what is MyProstateScore 2? How do you utilize it? And what information is it giving you that says, yep, is it a certain threshold number, a cutoff, if it's beyond this or that or the other? So take it away. Let's take it back now that we kind of have had people probably asking, like, what is this thing? All right, What is this? All right, here's your answer. Here we go.
No problem. So, so what is the test? I'll start with little bit of a background, and that being that, as you know, PSA, right? PSA is expressed by prostate cells, prostate epithelial cells. And so that is the reason why it is a non-specific test, meaning that it can be elevated for many causes other than prostate cancer. Mm-hmm. Because I always tell patients, it gives us a broad, indication of whether we need to look into something more. It tells us if it's elevated that the prostate is either enlarged or growing or has been irritated by an infection or some type of inflammation. It does not tell us that that's necessarily a result of cancer. And so where the biomarker tests improved upon PSA is that they all include markers, something that can be measured in either the blood or the urine, that is associated with cancer, not just prostate, but prostate cancer. Mm-hmm. And so that is what has enabled those tests to take that population of 100 men with an elevated PSA. We know only 20 of them have a significant cancer, and those tests allow us to say, okay, we can rule out needing to do a biopsy, rule out the presence of significant cancer in about a third of them, let's say 30 to 35 of the 100 men. And those tests, the prior generation of biomarker tests before MPS2, all include between 2 and 4 of those cancer-specific markers. And so where MPS2 sought to improve upon what already existed, those biomarker tests, was through two main mechanisms. One was, it's kind of the caveman thought, just being, well, if they only have 2 or 3 markers, let's include a whole bunch of cancer-specific markers. Right. And as silly as that sounds, right, it took a lot of innovation and technology to be able to do that at a cost that makes sense for the population. And so MPS2 contains 18 cancer-specific markers, that are measured in a simple urine sample.
Are some of these urine markers similar with what you would find in some of the other ones, or are they complete? Yes. So they are that plus more.
Correct.
So I've always
some overlap there with the other urine-based tests.
Right.
It contains several of the markers contained in the other urine-based tests.
Fascinating, and here's why. Again, going to your caveman way of thinking, SelectMDx have these, ExoDx have these, and they both. There's not that these two are, one is necessarily better than the other, depending on what research you read. And they both show something with regards to being helpful to figure out who needs what. What if we combine these with this? Just kind of combine a bunch of these together, and maybe you come up with a better result. Why didn't I think of that before the founders of MPS? MPS, you and I, it would have been just you and I. We would have been the founders of this company, and that's it. You could close your practice and we move on to,
Wouldn't do it.
Neither would I. Neither would I.
Right. That's what gets us out of bed in the morning is
exactly. No, I love this, and I love what I do here with this show. So are there any other genes out of the 18 that are unique to MPS 2?
Oh, absolutely. Yeah. The majority of them are. There's some overlap from the other urine-based tests, but the majority of them are unique. And to that point, right, I said there were two main mechanisms that this test should have and appears to have improved upon the tests that already existed. The second one being that we looked for markers that were specific for the higher grade cancers. So, that the previous generation of biomarkers certainly improved upon PSA by being cancer specific. But the other thing that's changed over the past 10, 20 years is that we've learned that, a large proportion of prostate cancers, the low grade group 1 or Gleason score 6, don't behave like cancer. And so our focus is on detecting the ones that do need treatment. And those are the higher grade cancers. And so in addition to looking for, and I can talk about exactly how we did that, but in addition to looking for cancer specific markers, we went looking for some unique markers that were present in higher amounts, so overexpressed, as we say, in high-grade cancers compared to low-grade cancer. And
define high-grade cancer according to the MPS2.
Yes, grade group 2, which equals Gleason score 7, group 2 to 5, Gleason score 7 to 10, because those are the cancers that do behave like cancer, do have the potential to spread, and that is how cancers cause harm.
And so for the audience, because they're saying, Dr. Gio, I heard you say before, and with other people, that low intermediate risk Gleason 7. So he just said Gleason 7 is high. Yeah, there is low intermediate risk Gleason 7 at 3+4, and there's higher intermediate risk Gleason 7. So there is some nuance in there, just to be.
Yes.
But this type of test will catch either, which I think you'd want to know. Ignorance is not bliss. I think you still want to know.
Yes, and that was, folks would ask, well, would it have made more sense to develop the test only to find, even higher grade cancers? And, our thought process, and certainly this was not just a few people, this is, based on experts in the field and just understanding the landscape of medicine today, we know that a good proportion of those more favorable intermediate risk cancers will ultimately require treatment. And so, like you said, we thought it made more sense to be more inclusive when developing and validating the test. And then additionally showed that the performance for the grade group 3 and higher cancers is even better, even stronger. And so the rare cases in which, in our validation study of over 700 patients, the handful of cases in which patients had a negative test but did on their biopsy end up having a clinically significant cancer, only one of those was higher than grade group 2. And so not only is the test, again, based on the data, highly sensitive for grade group 2 and higher cancers, it's astronomically sensitive for the even higher grade cancers that nobody would argue that we can just ignore.
Great. Is there ever a point where it's showing high grade disease, but the PIRAT score is a 2 or 1?
Yes. So absolutely. And
on an
these
MRI.
Things,
just to be clear.
Yes. Yeah. No, great clarification. Yes. And that is right. Being honest, that's my fear with trying to use MRI as a rule out test, right? I told you when we started talking, my thought process 7 years ago was if we have a patient who is at elevated risk of having a cancer that could harm them, if we're going to go and then make the decision, not to perform a biopsy, I want to be darn sure of that. And, I think most patients and most clinicians would agree. And so, the data tell us that the miss rate of MRI, so a negative MRI in which a significant cancer is present, is, of course, like all these things, there's a range across several studies, but I think it's fair to say it's unacceptably high for the majority of patients. And that's where my concern with using MRI to rule out the need for a biopsy comes in.
Any idea? So we know there's like 2 to 3% of patients that have aggressive disease with very low PSA. Most of them are what's called neuroendocrine prostate cancer.
Yes.
It'll be great if this can pick it up. So any idea if MPS2 can pick up some of these endoendocrine cancers?
Yeah, not as of yet, right? We, as you presume, when we sat down to develop a test, that the goal was to help as many people as possible, help the population with this problem. As you know, the neuroendocrine tumors are fewer than 1% of prostate cancers, and so it's rare enough that that's not something we've been able to look at yet.
All right, let's get to it.
Oh,
like you can't look right. You can't look at it. And you're right. You
don't need to be kidding. We are. We're looking at all these things, and hopeful that
I don't know. I know
strong.
you feel the same way, Jeff. Look, in my work, right, I see what I try to do, and my patients don't. I never say I'm curing your prostate cancer with lifestyle and natural medicine. Not what I'm doing. I am building health as somebody else treat disease. So I'm building your body up. What happens from that? Well, your quality of life as you go through this journey should be pretty good, even despite anything, even despite ADT for that matter. You should be okay. And if there's anything that's happening to cancer cells, I'm just trying to create a microenvironment in the body that's hostile to these cancer cells with these natural methods that includes exercise and eating better and certain supplements, right? That's all I'm doing.
Yes.
So the reason why I said about the neuroendocrine is because at this point, I think I've seen, close to 9,000 prostate cancer patients and over, not because I see so many a day, not like you guys are animals in that sense, but because I've been in it for a while. You always think of the ones that you didn't help.
100%.
And most of my patients come in and they say, man, I'm in better health today than before my diagnosis. This diagnosis was a blessing because I'm in actually better health than I was before, right? So, amazing, a large amount do well after prostate cancer, do well for a long time. You're always thinking, man, how did I, these few that you couldn't help? So that's why, 100%. Thinking of those, the 1% with neuroendocrine or whatever, it came to mind.
Absolutely.
All right. So what am I looking at as a clinician? Because I never ordered one. I know the numbers and all the different other cutoff points for all the different other tests. I have no idea what I'm looking at with the MPS2. So what am I looking at?
Yes. So, a urine sample is sent off, if you will, sent to the lab.
Do I need to do a digital rectal exam massage before having them urinate in the cup? Because that's been a deal breaker for me. So, and the answer is?
Right. The answer is no longer.
Man,
no longer.
Great.
So the original publication of MPS2, which was published a year ago, April of 2024, that was based on urine samples that were obtained after a digital rectal exam. As you know, digital rectal exam has, fallen out of favor, not to say it was ever in favor with patients, but, in our national guidelines, it is no longer considered a required part of the workup for an elevated PSA.
Excellent.
And, patients, of course, would rather avoid that. Yeah. And so that's what we've done, over the last year and a half, started on this before, that last paper was officially published, we recently have validated the test in urine obtained without a rectal exam and found, darn near the same really impressive performance in terms of accuracy. And so that, has opened up access to the test.
Love it.
Widely, right? It can now be ordered for at-home testing. The kit can be sent right to patients. They can urinate in a little contraption, put that back in the mail. Mm-hmm. Doesn't have to be temperature controlled or anything like that. And 5 to 7 days later, the result report comes. That is set up to individualize the risk of clinically significant prostate cancer in each patient based on their urine sample and optionally including some of the common factors that we look at when we're talking about prostate cancer, like age, previous biopsies, whether they've had previous biopsies, a family history of prostate cancer, and a couple other pieces of data. Those are optional. And the report comes back as a percentage likelihood that if that patient underwent a biopsy the next day, that biopsy would detect clinically significant prostate cancer, so Gleason score 7 or higher, grade group 2 or higher. And it's actually a little dial, that comes on the piece of paper. There's a dial that says, low risk, and gives the exact percentage risk of finding clinically significant disease. And so even though these tests were, validated to, or even though the test was validated to a specific cutoff, because that allows us to share, statistics like sensitivity, specificity, and predictive values, it actually, for each individual patient, gives their individual personalized risk, percentage risk of having higher grade cancer that would be detected on a biopsy.
Simple.
Yeah.
It sounds simple. And simplicity is so important these days. Everything sometimes is so much sludge. Things are so complicated, right? So
Yes.
Simplicity matters.
Yes.
All right. So I guess it's that simple. Patient comes in. Is there a PSA that's required to order the test? So they have to be above X, or I don't know. If I have a 40-year-old patient with a PSA of 2.1, I want to get this test. So is there some sort of cutoff?
It's a great question. So the validation was performed. So, for listeners, validation is essentially, once you've developed a test, you then apply that test to a new population, because if you develop a test in population A, most tests are going to do pretty darn well in the population where you developed the test, because it was based on that specific population. And so, the real question is whether it applies to other populations that meet that same profile. And so the test was validated in patients with a PSA greater than 3, or those with a PSA less than 3 who had a suspicious rectal exam. Right now, there are limited data that look at some outliers, and that's included in the publications, and ultimately it appears to be similarly accurate in patients like those you mentioned who had a slightly elevated PSA, but those the numbers are limited in that regard.
How about as it relates to racial diversity? So any genetic test that, the genetics, studies show the genetics, this group, is it 80%, 90%, white Caucasian versus Asian versus Latino versus Black? And what do we do with that information if it doesn't show that it's the case for say African-American males?
Yes. Another just awesome question. This is terribly important, right? We know that Black men are disproportionately affected by prostate cancer. I actually did a podcast just a couple weeks ago, Real Health Black Men, with now friend, I would say, who I met through patient advocacy. And this is a huge, huge matter of importance. So as of right now, the data, so our validation set, our training set included only between 5 and 15% Black men. We know that Black men, despite, being disproportionately affected by prostate cancer, remain generally underrepresented in these types of studies, these cohorts. And so, when we wrote the grant that ended up, funding both of the grants that ended up funding the work for MPS2, one of the aims within the grant was to say, okay, there are some reasons to believe that the test, that all of our tests available may not perform the same in Black men as they do in white men. There was recently a publication in the Journal of Urology showing that MRI does not perform as well in Black men as it does in white men. And there are some tumor genomics that can explain this, but without getting into the weeds too much, this is a really important topic. And so what we're doing now is collecting a cohort of African American men to test the accuracy of this MPS2 test the same way, it was in a larger population of Black men. If we find that it does not perform as well, we will then develop a new test in that cohort and find a second cohort in which we would then validate that test. So, I don't necessarily anticipate this, but it's possible that, in the coming months to a year or two, that there is a separate model used for testing in Black men for the MPS2 test. And I say model meaning, the calculations, kind of the behind the curtain part of it, the testing part would be no different.
That would be great because for obvious reasons, right? Like, if I do any test, any biomarker test, and on an African American male, I want to trust that that's accurate before I send them off, because I'm trying to save them from getting unnecessary biopsies, right? And 100%. But if I drop the ball, that'll be horrible, right? So I guess you'd have to look at. I mean, PSA still matters. Yes. PSA still matters. Yes. If something, wherever there's smoke, there's fire, right? If a PSA keeps rising, right? I don't care what anything says, just keeps rising with high velocity, then that will trump everything and say, look, this is not looking right. We need to figure this out. So yes. I think if you look at the overall picture and all the you put the puzzle together, you can figure it out. But if I'm banking just on this test, which maybe the answer is you don't just bank on just one test, particularly in African American males, maybe you just look at everything else and you help them figure it out that way.
I'll tell you, we were able to look at this in a larger population for the original MPS test, which contained three markers, and found that using the same testing approach that was used in the overall population, which was predominantly white but not completely, the rule out ability of MPS was, it could rule out significant prostate cancer in Black men with the same level of accuracy as it did in white men. There was a little bit of a trade-off, though, that there were, if there were 100 white men, and you're able, to rule out in the best case biopsy in 50 of those, the proportion of men that could have a biopsy ruled out was lower in Black men, but in those that had a negative test, it was, similarly accurate, very, very highly accurate, which was reassuring to me that at least, right, there's certainly no harm coming from use of the test. But that being said, it should be performing, we're doing the work to make sure that the test is serving all populations equally.
All right, Jeff, you've been very generous with your time, so I want to be respectful of that. I do have one last question. Guys on active surveillance, I'm trying to avoid for them to get, again, unnecessary biopsies. I guess you still need a confirmatory biopsy. So a lot of my patients say, I'm not doing it if I don't need to. They still saying I'm not doing it if I don't need it. Can we use the MPS2 to say, okay, with baseline, we get this, it shows this. You get on active surveillance, and then in a year from now, do another MPS2, and we'll see what that says. And I know you're going to say, we haven't studied that yet. We will be looking into that. Okay. But
I can do you one better. I can do you one better on this topic. We are very actively studying this, and the early findings in almost 200 patients, and I anticipate that as that gets closer to 300, that's when we'll move toward publishing the data. Just looking at the biomarker active surveillance literature that exists, that's generally been the number where folks will publish that. In nearly 200 patients, I have to tell you, as I mentioned to you briefly before we started, right? I keep a very...
Control your emotions, Jeff. You are a scientist in a major academic institution, yes. Which is what I don't follow, by the way, being in a major academic institution.
Yes, I am. I remain very even keeled about these things. The data for active surveillance that we have as of right now are so promising. And, I anticipate that within the year, we will have published that this test can be used in place of a biopsy, with the usual caveats, right? As is the case using it as a diagnostic test, it's not 100%, but it appears to be, again, upwards of 90% of the time that MPS2 in these active surveillance patients correctly tells us whether or not we need to perform a biopsy. And, I always say that active surveillance population is where biomarkers have gone to die in the past, because
I love that line. Yeah, you said that.
None of these tests, even the tissue-based tests, none have been able to predict the results of that next biopsy. Importantly, whether or not it shows higher grade cancers, because the population is so homogeneous, so similar. All these patients have low grade cancer.
Yeah.
I was hopeful that, by including the higher risk markers in this test, it could make the difference. And, we don't know yet whether or not it is, those specific markers, but the test does appear to be providing a level of accuracy in active surveillance that I haven't seen, short of biopsying everyone. And so that's
exciting.
Really
I have
exciting.
to say that's really exciting for me.
Yes.
So I'm glad you guys are doing that.
Yes.
Jeff, final words, and how can people find you? Because I tell you, I have a couple of patients from the whole Tennessee area, certainly Nashville, nearby Nashville, and they're looking for you guys. So how can people find you? And final words, any ending thoughts?
Yeah, sure. I think, final words, I'd like to kind of bring up what you brought up when we started this conversation, and that is that, your physicians, your urologists, really, we are, of course, there are, probably some exceptions, but folks are trying to do what's best for you as the patient. And, finding a physician, clinician that you feel comfortable with, having these conversations with, knowing that they are really invested in what's best for you, goes a long way. At the same time, right, I know there's a lot of fear or apprehension, might be a better word, about prostate cancer screening, right? The thought of the old rectal exam and, having to get a biopsy performed that, 20, 30 years ago, like I said, about 80% of those biopsies would turn out to be unnecessary. That's no longer the case, right? The rectal exam is all but by the wayside. And, we now have several excellent tools that can help us get from, okay, we have an elevated PSA, without going right to time for a biopsy, right? We're really doing our best to reserve biopsy only for those patients where we're fairly certain that there's a cancer that we need to detect and treat to benefit, patients' quality and or quantity of life. And so, don't, for lack of better words, I 100% get it, right? I always tell patients when we're doing a biopsy, I say it's uncomfortable, should not be painful. I'd be lying to you if I told you I had a line around the corner of men that want a prostate biopsy. Right. But, by the end, 99.9% are like, that was all? I thought that was going to be a lot worse.
Right.
And so, yeah, there are great tools out there now, and I would, do your best to find a physician you feel comfortable working with and take care of yourself. In terms of reaching me, I do check in on Twitter or X from time to time.
I would not say, based on our conversation before we started recording, I would not say that's the best way to find you at this moment in time.
I check in.
You don't want to be distracted. But there is, I will put, I'm sure there's a link to a website where with your profile.
Yes, I'll absolutely give you that. The website for more information on the MyProstateScore 2 test is through the lab, which is called LynxDx. So lynxdx.com, I believe.
Beautiful.
And, that's the best place to get information on the test. And you can get information to, go in to talk to your doctor about the test. Though I will one last time just mention, like we talked about, I happen to have a great deal of faith in this test based on, the work we've done and published. That being said, there are, other very good tests available. And, it's most important to just be working with someone who uses these tools appropriately to do what's best for you. And if that's a different test, that's quite all right as well.
Love it. Jeff, again, thank you so much. Dr. Jeff Tosoian. I knew I was going to butcher it. That's why I was trying to avoid it as much as possible. But you'll be linked up. Hey, thanks again, man. I really appreciate you. I appreciate your passion that you have for your patient and the focused, tireless work you've done around this particular biomarkers as you were a fellow. So thanks for everything you do. So pleasure to have you here.
Thank you. Thank you very much. And, I'd be remiss if I didn't mention, I think it goes without saying, but obviously huge team effort, developing and getting a test like this out to be available. And, it's a great team. And I'm lucky to be a part of it and appreciate you having me on.
My pleasure. Thanks again, everyone, for watching or just listening to the Dr. Gio Prostate Podcast with an expert around not a new biomarker, but one that's making a lot of noise scientifically in its research, and I think it's going to take hold, called the MyProstateScore 2.0. So ask your doctor about this. And as always, we just want you to be proactive, be a self-health advocate, ask better questions when you go in, and be in charge of your own health, both through lifestyle, natural means, and going to your physician and just being prepared and asking better questions. So thank you for listening. We have more coming. Dr. Gio signing off. I'll talk to you next time. Much love as always.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.